Yeah, so we have a trial. It's actually led by Dr. Oni Chan at our institution, for its work. She led both CPX-gilteritinib and CPX-Gemtuzumab studies, an excellent faculty member within our group. But essentially, for frontline, again, CPX clearly better than 7+3. Gemtuzumab does add benefit in particular the subsets. So really putting these combination together. So it's not a huge cohort, but the vast majority, essentially 90% of our patients had responses. Almost all of them MRD negative, and outcomes for patients both with and without transplant have been remarkably good. So I think if CPX-351 could be further developed from a pivotal strategy, I think we could argue that a randomized trial looking at CPX-GO versus CPX, again in p53 wild type, which was required essentially in this trial, and then we've done it in all-comer risk based on ELN, but we could look at subsets both in good risk, let's say NPM1 or core binding factor, where actually our outcomes, again, the patients are really not relapsing from that perspective, or in the group that's higher risk, can we further improve outcomes to strategy? There's going to be another abstract at this Congress, actually was comparing CPX versus 7+3+GO, and actually there was no major difference. So I think if you're putting everything together, maybe CPX-GO could be a very exciting combination to look in prospective frontline trials. I think, can we get everybody to play together from that perspective, as some of these agents are getting a little bit longer in sort of their shelf life from a patent perspective, is an interesting question, but we think that the combination is both really well tolerated and quite synergistic. The dose most likely is going to be 1 day of Gemtuzumab, but we're kind of further optimizing day 1 or 2 days of Gemtuzumab with the induction cycle of CPX.